So an orthotic, and this is an example of one here, are a device that goes between you and the ground. So they're acting as an interface. You'd be very familiar with spectacles on people's faces, and those are eye orthotics that are improving people's function. So the purposes of spectacles are to reduce the strain upon your eyes that you might be struggling with if you're very long-sighted or short-sighted. But also by wearing spectacles over a period of years, you're going to mitigate against the rate of degradation of that eyesight. And that's exactly the same for many people with the use of foot orthotics. Now, many people are never assessed for this. In fact, research has suggested that at least 75% of the population would benefit from having orthotics in their shoes. So many people who have a gait scan assessment at Reflex will be referred to that process by seeing one of the chiropractic or osteopathic team. However, also we see a lot of people come into the centre who come in purely to have their foot mechanics assessed and see whether orthotics are required. So as an example of a foot assessment, today we have one of our lovely patients, Casper, who's 11. Patients obviously come in of all ages. We assess people's foot mechanics from about the age of 3, and the eldest person we've assessed is in their 90s. Great, so we're just having a quick look here at Casper's feet and just see some of the basics that I can see. And then if you are assessing your own feet or having a look at yourself in the mirror or one of your children's feet, is there something that's self-evident that you can see? So first things first, if you look at these bony bits that stick out on either side of the ankle, these are called the malleoli. This is the medial malleolus, this is the lateral malleolus. You can see with Casper that if we drop a plumb line down off these, I'm going to hit the ground here a couple of centimetres away from the foot. Whereas on the lateral malleolus here, if I dropped off there, I'm dropping straight onto the skin. Now that shouldn't be the case. With both of these, I should be just coming down, just skirting down the side of the foot and landing next to the foot. Next thing, if you just look at the medial arch behind the big toe side of the foot this is, I should be able to take 2 fingers and be able to just push them underneath the arch there up until that first knuckle. And with Casper, it's just not there. I'm just pushing straight into the skin. Next thing, if I was to try and lift up his toes, they should lift up really, really easily to at least a 45-degree angle. And with him, they're really, really stiff down to the ground. So what can we see that can change that? Well, if I took the foot, in this case with myself, and I'm going to roll the foot away, and just hold it for me there, please. Ignore the front of the foot at the moment, but can you see how now the angle through here has changed? And if I was to drop a plumb line down here now, it's just adjacent to the foot on either side. But what we can see with Casper is that with this adaptation here, the big toes come up into the air. And this is due to the fact that he has a twist essentially in the foot from the front of the foot to the back of the foot, and really needs an orthotic that is going to come under here and support the foot. So when he puts his weight on it, the foot's in its neutral position. Right, Casper, so I'm just going to explain to you a little bit about foot mechanics. So first things first, the foot's made of 3 main areas. You've got the rear foot here, which is these 2 big bones at the back. You've got the midfoot, and then you've got the forefoot, which are these toes and these big long metatarsal bones behind them. Okay? Now, what we should be seeing is that on a normal foot, that the Achilles tendon looks absolutely straight down here, that there's a nice straight arch down the length of the foot here, and I should be able to get my fingers underneath the middle of the foot here, underneath that arch, okay, up to about the first knuckle of those 2 fingers. Also, I should be able to lift the big toe up to at least 45 degrees, if not a little bit higher, without feeling like it's hard work, okay? Now, when we're looking at your foot at the moment, it doesn't look like that, okay? It looks a little bit rolled in. So if we add into this the bottom of your leg, so this is the tibia bone and the fibula, those lumpy bits I showed you that were sticking out on either side of your ankle. So that drops down on top of there, and those are the bones that should be just skirting down the skin, okay? With you though, your foot looks a little bit more like that when you're standing, all right? So this is why if we dropped a line off here, it comes away from the foot, and it's why the arch looks lower. And also, can you see how there's a lot more load on this side of the foot here? And this is why it's harder for this big toe to come up in the air. Now, when you're standing like that, we can't be certain of why the problem is doing that. So that's why I got you to lie on your tummy and on your back as well, okay? So Casper, these are the super 3D scans that we did of your feet. Now, if I make this a bit bigger, can you see, as we look down the leg here, the line of your Achilles tendon, which is that tendon at the back of your leg, looks nice and straight all the way down. And can you see how the base of your heel looks nice and flat and level? And that's perfect. But then if we make this a bit bigger still and we roll the foot forward, here look, you can see where the ball of your little toe is, and here is the ball of your big toe. And if I roll the foot back down again now, so you can see that the little toe and the heel are aligned, can you see where your big toe is? It's just tilting up at a funny angle, okay? And this is why this is exactly the same position as when I rolled your foot out when you were standing up before, and when I rolled your foot out, you felt that the big toe starts to come up into the air. And that's exactly why. Another thing that's very important about orthotics is their practicality. So it depends very much on what kind of footwear you are using as to what kind of orthotics may be appropriate for you. If you're a long distance runner or just a weekend warrior or just like to go to the gym doing anything high impact, then an orthotic like this, as an example, is a sports orthotic and is designed for all those stresses and strains in mind. But an orthotic like that, for a man or a lady, is never going to fit into a fashion shoe. On the other hand, this is a casual orthotic. So these two orthotics were made for exactly the same person to the same prescription, but they look very, very different. So whoever we assess at the centre, we've got to decide first of all, is there any rationale for the use of orthotics? If so, what is most appropriate for them? And what is their need and requirement from those? Bespoke prescription-made orthotics like these have a very long life expectancy and are absolutely specific to you and your needs, but they may not be appropriate for you. We also have a wide range of pre-made orthotics that we certainly use more commonly with children and adolescents, especially if their feet are still growing. And the best time actually to assess this is in childhood, because in childhood the body hasn't had any chance to adapt to any stresses or strains further up.